an idea of really what was going on. And so we have five, and that's great. So Dr. Boniface from the emergency department, who most of you know, has graciously offered to sort of be the moderator for this group and introduce them as people as they come on. So Keith, why don't you get started? And thanks for being here today. Thanks for doing this. I appreciate it.
Great. Thanks for having me. We're going to chat today about a kind of a broad range of topics that came up during this COVID-19 surge. I'm going to start by talking about ultrasound and COVID. Andrew Meltzer is going to talk about the ED registry. David's going to talk about airway management. Dr. Haile-Mariam is going to cover a myriad of topics, and then she's going to also cover Dr. Sika's ED response and reopening strategies because he couldn't be with us today. So without further ado, I'll start off by talking about lung ultrasound. And I think for this particular micro talk, I want to talk a little bit about the artifacts that we ran into and that we use in pulmonary ultrasound that makes up the pictures that we use to diagnose common pulmonary pathology, and then really focus in on the appearance of COVID-19 infection on point of care ultrasound. And then talk a little bit about the role of point of care ultrasound in the COVID-19 pandemic. And so with that, ultrasound of the lung is different from all the other ultrasound that's done in our hospital. Ultrasound of the heart, ultrasound of the abdomen, all of these ultrasound images are anatomic pictures that are formed. The ultrasound beams bounce in and bounce out of the patient. But lung ultrasound is different because it relies on artifacts. And these artifacts are what make up the pictures that help us to diagnose various conditions. You can use either the linear high frequency probe like we use for central lines. It's very good for diagnosing pneumothorax versus the phased array probe for other indications. And the nice thing about it is it's not anywhere near as operator dependent as all these other tissue-based ultrasounds of the heart and the abdomen. And we found lung ultrasound in general over the past several years to be very useful, differentiating the dyspneic patient, CHF versus COPD, identifying pneumonia, ruling in or ruling out pneumothorax in the trauma bay or post-procedurally, and both diagnosing and managing pleural effusions. And so those who invented lung ultrasound have come up with various protocols. The most common is an 8 lung zone protocol that divides at approximately the nipple line and the anterior axillary line to divide it into 8 zones anteriorly. And so you take your probe and you place it in the anterior chest wall here with the orientation mark towards the head, and you bridge a couple of rib spaces. And then that pleural line is just deep to those ribs. If my clinical question at the bedside is, does the patient have a pneumonia? Does the patient have signs of COVID-19? Then these posterior lung fields are added for a total of 12 lung zones. And these posterior lung fields are very helpful for identifying lung disease. And the artifacts that we're trying to see are a few. This shows an ultrasound against the anterior chest wall. The probe is touching the skin here, going through the soft tissues of the chest, then the muscles of the chest wall, and then reaches the ribs. Now the ultrasound beam can't get through the rib, so it bounces off the rib and leaves this big shadow behind it and gives you a bright shadow from here. And similarly here, you have a second rib with a rib shadow. Just deep to those ribs, you have this sliding bright white line. This is the pleural line lung sliding. And that lung sliding are the two pleural surfaces moving against one another. Some people describe these as ants marching, shimmering, whatever you want to call it. It's just this motion that tells you that those two lung surfaces are sliding against one another. Another artifact you can see on this slide is called an A-line. This is fake. It does not represent anything you're seeing actually in the lung. This is just a mirror artifact, a reverberation artifact reflecting off of this line. And you can see it in either healthy or diseased lungs. Another artifact that we see are called B lines. Now this is the pleural line is up here, with lung sliding, and you see these comet tail, bright white searchlight laser beam-like artifacts that arise from that pleural-pleural interface and go all the way to the edge of the screen. And these B lines are very helpful when we're trying to diagnose congestive heart failure, pneumonia, COVID-19. What are these artifacts? Lung sliding means that at the point where your probe is displaying this, that there is no pneumothorax. If you see this shimmering, this sliding, it means that where your probe is sitting, there is no pneumothorax. So to rule out pneumothorax, you need to look at multiple lung zones, but in the supine patient, this ultrasound exam is much more sensitive than a supine AP chest X-ray. Absent lung sliding it is seen anytime that a pneumothorax happens and air separates those two pleural surfaces, or anytime those two lung surfaces stick together. So it signifies a possible pneumothorax, but you also see it anytime the lung is not sliding for another reason. If there's scarring, if the patient's undergone pleurodesis, if there's ARDS and the lungs are just very sticky and inflamed, or if this is the left chest and the patient has had a right mainstem intubation and the left lung is just not being ventilated. These A lines you can see in both healthy lung and abnormal lung. If there's lung sliding here, that's an indication of healthy lung. Absent lung sliding, that picture could totally represent a pneumothorax or other causes of lack of lung sliding. And B lines really signify, just like curly B lines, a thickening of the interlobular septa by fluid, fibrosis, infection. And if these B lines are diffuse and bilateral, it tends to imply a diffuse process, most commonly in our ER, pulmonary edema, but also PJP pneumonia, pulmonary fibrosis. They can all have this diffuse laser-like pulmonary B lines. If they're focal and unilateral, they can be in the areas of a lobar pneumonia or patchy distribution like a viral pneumonia or COVID-19. Other pathology that we see on lung ultrasound, we can see pleural effusions surrounding atelectatic lung. We can see complicated effusions like these loculated effusions with fluid levels and septations that you wouldn't want to put a chest tube in. This is something that's more complicated. And you can also see lobar pneumonia. You have liver here. You can barely make out the diaphragm here. And on the head side of the diaphragm, you have what normally is lung. An aerated lung would prevent you from seeing anything deep. But this consolidated lung as a lobar pneumonia conducts these sound waves through, and you can actually see the line here. So COVID-19, there are some challenges that you have to focus on first with COVID-19, first and foremost being infection control concerns. We want to make sure our providers stay safe. We want to make sure that the next patient that has an ultrasound by that ultrasound machine stays safe. And so, being careful about who you use ultrasound on and how you clean it afterwards is important. It's important to realize that not all B lines are COVID-19, even when the disease is prevalent. And people who present with COVID-related cardiomyopathy and congestive heart failure will have diffuse B lines, just like someone pre-COVID who has decompensated heart failure. And so correlate it with the clinical picture and with other views, including echocardiography. But we found that these ultrasound images are very sensitive for some of the pleural and parenchymal changes of COVID-19. And the things that are seen are a thickened pleural line and with an irregular pattern to it. So as opposed to the pleural line we saw previously, this is very jagged, almost moth-eaten here, and has a very thick, bright white line as opposed to the thin sliding we saw earlier. You can see these searchlight B lines in a variety of patterns, and you can also see subpleural consolidations. So instead of the air at the pleural surface reflecting back the ultrasound beam as a pleural line and lung sliding, subpleural consolidations allow the sound waves to get a little bit deeper into the lung and you can see tissue-like densities that are lined up against the pleural space. Now, most of the time, we don't see pleural effusions of any significant size with COVID, although you can see small rims of fluid around these subpleural consolidations. And in all of these findings, the posterior lung fields and the lower lung fields tend to be the highest yield, as Dr. Pang noted early in the pandemic, and Dr. Liu and her colleagues from around the globe have reported from an international webinar on lung ultrasound. This is all from one patient. Unlike those laser light B lines that we saw earlier, this is almost confluent. It looks almost like a waterfall going straight from the pleural line here all the way to the edge of the screen, with some irregularity to the pleural line as opposed to that nice smooth line. And here you can see a little area where your ultrasound beam gets into the lung tissue itself because of that subpleural consolidation. And again, pleural thickening, subpleural consolidation, and a very irregular pleural line. Similarly here, very irregular pleural line with pleural thickening and subpleural consolidations where the ultrasound beam gets into the tissues. Now, one caution about ultrasound in the world of COVID is that not all, the lungs can look terrible and the patient look good. So it hasn't replaced clinical judgment and where patients are best served. If you search the hashtag #MyCovidDiary, it brings up Yale Tung Chen's ultrasound diary. He's a POCUS-trained physician in Madrid who contracted COVID early in the pandemic, and then documented daily ultrasounds on Twitter that span the spectrum of findings of COVID. And so, but he was an outpatient the entire course of his illness, despite having horrible looking out lungs. So pulse oximetry, clinical symptomatology are still the best indicator of who needs inpatient care and ICU care. Anyone looking to learn more about point of care ultrasound and COVID, or lung ultrasound, or ultrasound in general, just Google ultrasound podcast. These guys have the best catchphrase in medical podcasting, and or 5 Minute Sono. Either one of them has a host of resources that have great videos. And then take-home messages. Ultrasound is great for identifying pulmonary lesions in COVID-19. Clinical assessment is currently better than ultrasound in predicting the need for inpatient.
I got the video. Let's see if I can get the audio.
And POCUS is very helpful in identifying other causes of dyspnea in COVID, such as cardiac decompensation and thromboembolic disease. But infection control is paramount, and these hand-carried tablet-based ultrasound devices can be great in order to cover the probe cover and allow for easy decontamination between patients. Well, I think we'll save questions to the end. I'm going to turn things over to Dr. Andrew Meltzer. Dr. Meltzer is our clinical research director and associate professor of emergency medicine, and he's going to talk to us about some of the research he's done in COVID.
I'm muted, but.
Thank you, Keith. Thanks for warming up the crowd. Thank you, Alan, for having us. Thank you, Department of Internal Medicine. I think that's Saul talking over me.
Yes.
So we have about 10 minutes. I'm going to go through a lot of material pretty quickly. On the right, we have a beautiful video of our enemy, the SARS-CoV-2 virus, on electron microscopy video, where you can see the characteristic crown. I know the video is not playing right now, but around the viral envelope. As most of you know, there's 7 different types of coronaviruses, 4 that were caused the common cold, and SARS-1, MERS, and now SARS-2. To answer Dr. Wasserman's question of what's it like in the ED without getting too touchy-feely, for me, the biggest issues are just the, I think, general mental exhaustion of was I careful enough, and the fact that the phenotypes are so varied with COVID-19 and changing our approach as ER doctors. I think we're used to being the people that sort of charge into the burning building, and many times I've sort of taken over bagging from EMS, and now the idea that you sort of walk away from a person who really needs you to protect yourself, it takes a lot of getting used to. And sometimes we do it, and I think sometimes I'm not as good about it. But the ED research in COVID, we've been very busy. We're doing a lot of different interesting work, working on patient registry and surveillance, risk stratification tools, early use of therapeutic agents, diagnostic testing, and also a lot of work with remote patient monitoring and telemedicine. My slides seem to be jumping around a little. These are the, we can skip forward. Thank you. These are the bell curves that we've all been looking at for the last 6 months. And one thing that's notable over the last 2 to 3 weeks is how we've sort of plateaued at very high rates. So it's August 20th today. This is data up to August 15th, but daily deaths have plateaued around 1,000 and cases around 50,000. That curve looks a little different than how it's looked in the past. And hopefully we can start to bring that down.
Just a second.
So the meat of my talk today is going to be talking about this multi-center registry for COVID-19 patients presenting to EDs in the United States. This is a registry of ED patients who are symptomatic or we think are symptomatic with the virus. So the intention is to exclude patients who we have a high degree of certainty that their ED visit's not related to viral infection. So that's all the trauma patients, the intoxicated patients, poison patients, some of the psychiatric patients, patients who are victims of rape or domestic violence. Those are all excluded. Combining, still on this. Is that Dr. Edelstein? Okay, thank you. And then when combined across over 50 EDs and 50,000 patients, this will be very powerful to develop clinical decision rules and detailed trend data. So I'll talk a lot about what's going on with our GW registry. This is essentially how the flow works. It's a rolling retrospective study where we get an EHR report of the patients who had COVID testing, and then we follow them with a deep dive on their ER course, on their hospital course, and follow them for 30-day outcomes. If they're still hospitalized, we continue to follow them. So this is a little bit about our registry. I basically just downloaded our first set of data earlier this week and just started to analyze. So we don't have a complete set yet, but this is about 2 months from March 7th to May 14th, second week of March to the end of the second week of May. 584 COVID positive patients in the ED with symptoms, average age 54, 51% female, 64% Black or African American, 20% Hispanic Latino. Private commercial insurance was 45% of our patients. And then of our whole group, we had 310 who were discharged from the ED, 235 who were admitted, and then 39 who were directly admitted to the ICU. Some of those admitted patients were eventually transferred to the ICU. I think it's about 40 or 50 were transferred during this time. So what I wanted to do was a deeper dive on those 3 categories. So the discharge group, the admit floor group, and the ICU group, and see if we can sort of get a sense of some of the differences. Dr. Edelstein, do you mind going to mute?
No, I can hear you. I can't get you on my, got you on my phone.
Okay. We can hear you chewing is the only thing.
I'm sorry, yeah.
So mute your phone also, please.
Thank you. So ED disposition by age, looking at that older group. So if you look at your discharge group, about 10% of our greater than or equal to 65 went home. And then you can see that trend going up if you look at our hospital admit group and our ICU admit group, and the opposite trend in the less than 40 group. And these are statistically significant. We're going to look again now. If you look at the national data, so the curve here is from the CDC. So looking at those early months, that blue and green line, those are older. It's 50 to 64 in the blue. Green is 65. And then the lower lines, that orange and grayish line, those were people under 18. You can see they were very low percent positive early. Fast forward to now, and those curves have completely switched. Higher rates of positive in our younger patients, lower rates of positive in our older patients. Looking at an ED disposition by sex, so back to the GW data, it's about equal in our discharge group. When we look at our ICU group, we see a preponderance of male patients, 62% to 38%. This one slide doesn't have a significant value yet, but I think when we get more patients, we'll start to see significance. The question we ask is, why do women fare better than men with COVID-19? It's an open question. Recent research is showing that there are differences in the immune response to SARS-CoV-2 pathogenesis across male versus female. Stay tuned to see how we can use that information to affect therapy. When we look at ED disposition by race and ethnicity, among the discharge group, 55% African American, but when you look at the hospital admit or the ICU admit, now it's 74% African American. Marked difference, statistically significant, excuse me. And then by insurance status, using this as a proxy of socioeconomic status, we look at our Medicaid group, 8% in the discharge cohort, it goes up to 21%, and then 26%. Opposite trend we're seeing in private commercial, 61% in the discharge, 30% in the admit, 11% in the ICU admit. You look at those dual payers, the Medicaid, Medicare, so those tend to be the older patients, may also be below the poverty line, 6% discharged, 33%, 44%. Seeing the social determinants of health play out here with all these different variables. I think as we know, it's a wide-ranging group of symptoms. This is a multi-headed hydra of SARS-CoV-2. It's one of the things that makes it so hard in the emergency room to work. Initially, we had this concept of the PUI. We worried about international travel, talked about cough and fever only. Now that stuff has sort of gone out because we realized just how many different ways that this virus can present. So I'm going to look at some of those different symptoms and again, break it down by the patients that were discharged, admitted to the floor, and admitted to the ICU from GW. So these were the symptoms associated with ED discharge. Now there is a little bit of a reporting bias here because these are self-reported symptoms. So you can imagine that a sicker patient's probably not going to tell us some of these more mild symptoms, but we are seeing some significant differences here, and I am hoping that these things will start to help us sort of guide which symptoms are associated with more acute presentations. So you can see ear pain is very uncommon. Runny nose is not very common, but more common in the discharge group. Sore throat, a little more common, again, more in the discharge group. All of these are more common in the discharge group. Dry cough, chest pain. Fevers we see, this is a history of fevers, not a documented fever, but 60% in the discharge group, 60% in the floor admit group. Muscle aches, myalgias, we see it across all three groups. Headache, we see a little more common in the discharge group. And then this olfactory taste disturbance that we've all heard about 15% in the discharge group. Remember, this data is from March, April, May, so some of the stuff might go up more as we learn more about the disease and ask more directed questions when we saw our patients. Looking at the patients who, looking at the symptoms that were not associated either with discharge or with admission, these were basically the symptoms that were similar across both cohorts. So the fatigue, malaise, we see it about 30% across all three groups. Joint pain is very rare. Abdominal pain, we see about 5 to 10% across discharge, floor admit, and ICU. Vomiting was interesting, about 20% across all three groups. No difference in terms of when we looked at across those three groups. Conjunctivitis was rare. Wet cough, about 10%. No difference. Wheezing was very rare. And remember, this is an adult population. Wheezing is going to be a lot more common in the pediatric population since kids tend to wheeze with almost every viral infection. But the uncommon things, we see joint pain, conjunctivitis, and wheezing. And the common things that we didn't see a distinction between were fatigue, malaise, abdominal pain, and vomiting. Those have no statistical significance. There was a question because there was no difference between the discharge and the floor. Now, when we look at this group, we do see a statistical significance. This is with the respiratory distress and failure group. Obviously, we're going to see a lot more in that ICU. Altered mental status, we see a lot more in the ICU than we see in the discharge group. Diarrhea I thought was interesting. Remember, we didn't see a difference in the vomiting group, but here we do see a statistical significance in the admitted and ICU group for more diarrhea. Syncope is not very common, but we see more in our admitted group. And then when we look at shortness of breath, we see it across all three groups, but more in the admitted group. If I see comments pop up, I'll try to answer them as we go. And then when we look at our past medical history, in terms of all three groups, the differences in the three groups are above the line classifications or past medical history that are below the line. We didn't see differences across all three groups. So diabetes, high blood pressure, COPD, ischemic heart disease, hyperlipidemia, congestive heart failure, cancer, and COPD. We all saw those conditions much more likely in the floor admitted in the ICU group. Obesity, smoking, substance abuse, asthma, and HIV/AIDS, we didn't see an association between disposition. We also looked at homelessness, which because I was interested in that, and we did not see a difference in the disposition based on homelessness. Pulmonary imaging, about 25% of the overall group had a normal chest x-ray. When we looked at our discharge group, about 36% had normal chest x-rays, and in the admitted group, still 15% for the initial chest x-ray done in the ED was normal. The abnormal findings that we saw, nonspecific infiltrate was the most common. These percentages are a little confusing because they lead up to the 75%, but not to 100% because it's out of the entire group. Cardiomegaly was common. Interstitial thickening, effusion, and atelectasis were less common. About 10% had chest CTs done, and of those, the most common finding was ground glass infiltrates in about 73% of the people who did have chest CTs. That's not of the whole group, that's just of the patients who had chest CTs. So we're all talking about the symptoms these are generally the acute symptoms. All these patients had a positive COVID test within 14 days of their ED presentation for symptoms. There is this new concept that we're seeing in the lay literature of the long haulers. These are patients with symptoms 10, 14, 16 weeks out, and that symptomatology tends to change a little bit, and that's an ongoing source of research. Looking at our mortality, so this is the 30-day death rate per ED dispo. Of the patients that we discharged from the ED, 1% mortality. The patients admitted to the floor, 17% mortality. I was surprised how high that number was. And then of the patients admitted to the ICU, 46% mortality. So this is a cartoon by Wiley, science versus everything else. Simple is often wrong, complex sometimes right. We are seeing a very complex phenotype, and we're still teasing out exactly the most common presentations and which presentations are most associated with bad outcomes. There's a lot more to do with this data set in terms of logistic regression and looking at other outcomes, including intubation and death. This was our first package, just looking at the 3 different groups of patients. Regarding complexity, I think I have about 2 more minutes. I just want to talk a little bit about therapy and some of the good news that we're seeing in time of COVID. Currently, we have a RCT out of the UK where dexamethasone reduced mortality for intubated patients and patients that required oxygen, but maybe caused harm in patients when it was given early. We have an emergency use authorization, which is sort of the closest thing currently to an FDA-approved drug for remdesivir, because of an RCT that showed a small reduction in hospital length of stay. But in that study, it was given later in the course of disease, or at least 10 days after symptom onset. On average, and so the thought is maybe if that was given earlier, maybe you could see a better, more promising benefit. And I'm very enthusiastic about interferons when used early in the course of disease. There's a lot of small studies showing positive benefit there. But again, when we talk about a complexity, it's not just getting the right drug, but it's about giving it at the right course in the disease. So some of these drugs will work early, and some of these drugs potentially can cause harm early. Some of these drugs will work late and potentially can cause harm late. There's very promising data for adaptive immunity, so solid B-cell and T-cell immune response. Right now, there's no confirmed documented reinfections, which is incredibly positive. And second to last, vaccine development is moving very fast. In January, our viral DNA sequence was published. Within days, we were making messenger RNA and doing animal trials and in vitro studies. 2 months later, our phase 1 vaccine trials, and 6 months later, we're doing phase 3 vaccine trials in GW. So I'm sure most of you know as a part of that. That's incredibly exciting how fast that's moving. Finally, Steve Bannon was arrested earlier today, so that's also good news. And that is it for me, I believe. So I think that was 10 minutes. Thank you so much. Please reach out if you have questions or if you have ways that you would like to collaborate. Thanks for having us.
Okay, next up we have Dr. David Yamane, who is our bridge between upstairs and downstairs, Chief of Critical Care Medicine section on our emergency department, and splits his time between the ICU and the emergency department. David, go ahead.
Thank you so much for that. I'm going to move pretty quickly. The things I want you to get out of this lecture, mini lecture, is first is the complicated factors that we put into when we're deciding whether or not to intubate the patient. Sorry, I'm going to be talking about airway and intubation. And then the second thing I want you to get out of this is sort of the safety elements involved with airway management. And then lastly, we'll be talking about a little bit of the prognosis from GW's data of respiratory support and intubated patients. So we will be moving on to, so the first question we have is always, should I intubate the patient? And there's a lot of things that go into this. The first is like logistics. This is a very high risk procedure. Unlike other sort of intubations that we have a bailout method, a lot of times we do not have a bailout method. The things we usually do to pre-oxygenate patients by bagging them, we aren't allowed to do in COVID, and we really only have one shot to do this. The second sort of thing that plays into logistics is the provider safety. If you imagine that the patient's airway is spewing virus and you're about to put your face right into that fountain of virus, it's quite dangerous for our providers. And so PPE plays a lot into this, and we'll talk a lot about that and how that affects your decisions on whether or not to intubate the patient. And then the final most important question we have about whether we should intubate this patient is the patient safety. And we like to intubate patients early because, as you know, these patients are very, very hypoxic, and they get very, very, very hypoxic very fast. And so they can go from a SAT of like 80 to a SAT of, single digits within a matter of seconds, and really avoiding that crash intubation, because unlike other crash intubations, it takes you about 5 minutes to get all your gear on. And then as we talked about, these patients are incredibly hypoxic already. And then the last question is, we're not totally sure that invasive mechanical ventilation is helping patients, and maybe is it hurting patients? And we'll touch on that. I don't actually have a great answer for that. Next slide. So some logistical changes. First is that we are using video laryngoscopy for all these patients. And the next is that I touched on is we're really not using our friendly ambu bag because we do worry about aerosolizing the virus more with this. And so we've sort of taken those totally off the table. I'll touch a little bit up on this, but we do use bagging in very judicious situations. And then the last sort of major point to all of this is going to be PPE. We've been very fortunate at GW to have PPE, but we're going to look at that next. And so on the far left, you have what your standard PPE looks like if you're going to meet your COVID patients that I think a lot of us are used to wearing. And then sort of next in the middle is what the PPE that's required for intubating, which is this PAPR. And you have to do a robot dance every time you put on a PAPR. But you have this extra layer of plastic in front of your face. On top of all of this PPE, we like to put another layer between the patient and the room. And so we started off by putting just a plastic sheet over the patient's head, which can be quite cumbersome. And so one of our advanced practitioners, Amy Kime, created this intubation tent with the GW Mechanical Engineering School. And it gave us a lot more room to sort of practice with this area, to a space to intubate with. But even that, you're putting your hands inside of a box and trying to do a very dexterous skill. And then finally, this picture is not, you don't need to adjust your screen. That blurry picture is what it actually looks like from within a PAPR. And so you imagine you're trying to do a very dexterous skill, and you are putting tons of layers, necessary layers of plastic between you and the patient. So next slide. We're going to next look at patient safety. Yes. This article just got published this week. It is put out by here at GW with a conjunction between emergency medicine, critical care, anesthesia, and ear, nose, throat, as well as partners from within our hospital as well. So what this study we looked at, for the next slide, we looked at our sort of safety practices within GW, and hopefully applying that more broadly to other hospitals that are going through this pandemic. The first thing we created was this intubation safety checklist that our safety officers helped us. The safety officers help us don and doff all of our PPE, and part of their job would be to make sure that we had all of the appropriate equipment necessary for the intubation. The second piece was that we had med student volunteers help us out, who would tiger text all of the intubators after an intubation within 24 hours and asked them if there were any issues with the intubation that we could address. From this study, we found, next slide, we actually did pretty well. Our intubation details, it was spread out pretty evenly amongst ICU, anesthesia, and emergency medicine. Most of our intubations would be done by our attendings because we wanted to be sacrificed, but also we wanted the most experienced person doing the intubation because we knew that they were sort of one-shot deal. And then, as it would imagine, most of the intubations happened in the ICU or the ED. On how we did with PPE, we did pretty well. If you looked, we almost hit 100% in most of the categories. The categories we missed on was a PAPR and an N95, which is actually not necessary. I do that just because it makes me feel extra safe, but you don't need both. And then the shoe coverings actually got removed from the necessary PPE requirements. And so those numbers dropped off. And then the last piece was that physical barrier or tent or plastic sheet, which was actually part of the things that we worked on. Next slide. And so we, through this sort of conjunction of all of our intubators getting together, we actually allowed for judicious use of BVM in specific cases. We expanded the medications in our RSI bag, and then we expanded the education to our intubators to make sure that they are using either the Chyme tent or the plastic sheet. And then we helped create a to-go bag with all of the necessary airway supplies. Moving on to the next slide. So then this really comes to the heart of the question: is to intubate or not intubate? In the beginning of the pandemic, we were so afraid that we would be aerosolizing the virus, and all of our respiratory support measures that we normally use, BiPAP or high flow, we were just afraid of them. And so we actually intubated a lot of people early. And there were actually several patients who we actually got on high flow and were doing okay. And we're doing okay. And then we actually intubated them because we're like, I don't know if that's safe or not. And then I think a lot of you are familiar with this JAMA article that came out from New York's experience. And it was really scary statistics. The one that always stuck in my mind is that 97% of people over the age of 65 who were intubated died. And that's like pretty much a death sentence for anyone who's over 65, which a majority of our patients were. And so we took a huge step back and we're looking back at our respiratory support measures. The first would be BiPAP. Looking at BiPAP in the other pandemics, H1N1, SARS, MERS, it had a huge failure rate. There's some problems with BiPAP. It can increase transpulmonary pressures in, an ARDS disease. When you're trying to do low tidal volume ventilation, you can't control the tidal volumes on this, and the patients can actually be taking huge tidal volumes. And if a patient fails this, you're stuck with a crash intubation with potentially a patient with a SAT of 9%. And then this has a high risk of aerosolizing the virus. At GW, we did some sort of MacGyvering things that we do. We put viral filters on all the exhalation ports, and then we did this in negative pressure rooms. And then we also created these BiPAP bubbles that our respiratory therapist, Joe, is showcasing. And so patients actually did okay in a couple days on BiPAP in their little respiratory bubbles. And so non-invasive, we had an okay experience with. I think something that we had a much better experience with at GW that you are all probably very familiar with, because the medicine service, thankfully, took care of most of the patients on high flow nasal cannula. And so in SARS-1, about a third of the patients in the ICU used this, and this actually avoided about a third of the intubations that could have happened. And so at GW, we use this very broadly on the medicine services on the floor. And I think that we were quite successful with this. The Society of Critical Care Medicine actually does recommend high flow nasal cannula over non-invasive. And though they don't have great studies to support it, they believe the aerosolization risk is actually lower than it is with non-invasive. So then the question becomes, what about GW? And so let's look at some of our numbers here at GW. This is from our internal admitted patient registry. We had about 370 patients. 93 of those were intubated. The average age was 57 years, and the average BMI was 32, which is quite big. Majority of the patients were Black. And the overall mortality rate for anyone who was intubated was 80%. If we break up what everyone looked like if they tried a respiratory support or not, so we had 47 patients who were just intubated right off the bat. Of those, 20 died, which is a 42% mortality. If you looked at those who tried respiratory support, high flow nasal cannula or BiPAP, we were actually able to stave off a couple intubations. But if you look at the mortality rates of those who failed those non-invasive measures, they're quite high, ranging from 81 to 100% of people who failed BiPAP. And so the big takeaways from this, I think, next slide, is that the people who tried supportive measures and failed had a huge mortality, and is something really we have to think about. But we were able to save about 64 patients from intubation, which is about 58% of our patients by these non-invasive measures. So the takeaway points I have is that the decision to intubate is a complex balance of logistics, provider safety, and patient factors. Provider safety around intubation should involve a multidisciplinary approach. And then lastly, you should try non-invasive respiratory support measures in COVID-19, as you may save a patient in intubation. However, failure of these non-invasive respiratory support measures is really associated with a high mortality. And that is probably a discussion to have with those patients who are failing their non-invasive measures. Thank you so much.
Great, thanks, Dr. Yamane. That was excellent. Our next speaker is Tananya Haile-Mariam. Dr. Haile-Mariam is known to everyone on the inpatient side. She's our triple threat, triple boarded colleague here who is going to talk to us. She's first going to present some things that she worked on with Dr. Neil Sika, who's our chief of telemedicine, about technology-enabled care in COVID. And then she will finish up talking about some of the kind of less discussed impacts of COVID on our emergency department patients. Go ahead, Tananya.
Thank you, Neil. Wow, we've covered a lot of ground, and I'll go a little more quickly through what we're going through now. So far, we've kind of looked at COVID and the ED and in the hospital, and we're going to switch a little bit and look at where our practice melts into the community. And the objectives of this first part is to let everybody know a little bit about our remote monitoring system and how that's an example of how we've changed the way in which we practice ED/outpatient medicine, and then a little bit about how our scope of practice and maybe the scope of practice of other people, other departments also has been affected. Next. So like everybody else, we started doing things that we didn't do before and started upping things that we did before so that we could better meet the challenge. And these are some of the ways we did that, and I'll cover a little bit on each one of these. So in February, we felt like it was a tsunami. I really like Dr. Axelrod's more choppy, large, unpredictable waves, because a tsunami is kind of come and gone. And clearly this is not going to become or gone anytime soon. So since February, we've done a couple of things to try to sort of surf these waves. One, we realized testing was going to be important, and I'll cover a little bit more of that as we go on. Two, the way in which we practice medicine was going to have to change. Patients couldn't just come to us. We couldn't just go to patients. And so how was it that we were going to continue to practice under these environments? We had to sort of change the way we did things, and flexibility was important. And here, PPE preservation, but also preservation of the practitioner became important. Next. One of the first things that we realized is that people were crying out for information. Our pitch to the DC government was the information is changing daily. Advice is changing daily. We all know what was going on with the CDC not providing us with guidance, etc. And people in the district were looking to get information and calling 911, calling 311, wasn't getting any response. So our pitch was, we could really help the city to get a better handle on how it wanted to put information out there. We got a grant and we put up our COVID-19 call center. We manned it with medical students who were not in medical school at the time and with EMTs, came up with a script that would answer what we thought were going to be the big questions that would come from the community, which we thought would be information on what COVID was, what to do about COVID, etc. Interestingly, very quickly realized the number one question was, where can I get tested? And so we kind of had to make a pivot, but it also was a telescope into the future of how testing would become important. We coordinated our efforts with the other hospitals in the district so that if we did decide after speaking with the person that they would need to see a practitioner, we could refer them back to home base. So GW-based patients could get referred back to GW, and patients that needed to go to the center, etc. So it was really a collaboration between us and the DC Health Department, and between us and our other colleagues at other hospitals in the district. About telehealth visits, we'll go through them a little bit more, but testing became very important. And here I just want to give a big shout out to our colleague, Drew Morano. There's a CNN type hero award that we at GW could give. He'd be at the top of my list, working tirelessly to try to figure out how we could get testing out there. I remember the first time we went out to test somebody, PUI, was that outbreak that we had, the first outbreak at the church at Georgetown. And we practiced donning and doffing in the department. And last minute we realized, there are going to be cameras in front of the house. So we quickly looked at our maps and we said, you can get to this house through the back. So you guys are going to go in the back alley, and then you're going to change in the back alley, and the cameras will never know you got in and got out. So that's the kind of last minute thing we were doing when we first started. And then of course, as we expanded, you all know about this, but other people might not know about is just how extensively we were able to go out into the nursing homes throughout the district and give on-site testing. It really was a gargantuan effort and very, very useful in containment. This maritime testing, as many people might not know, we provide distance-based medical consultation to probably thousands of ships around the world. And you have probably been seeing a little bit in the newspapers about the shipping industry, the cruise industry, etc., and how difficult it's been in the time of COVID. So we have had to expand our testing portfolio out beyond the borders of our city, and I'll tell you a little bit more about that. But again, we sort of perfected things, or tried to get us close to what we could use at home base, and now we're starting to roll out systems a little bit to the outside. Again, this is from the ED out, not from the ED in. Next. Again, we call it PPE conservation, but it's really practitioner conservation. How do we get the services that you would get from that whole team coming into your room? Sorry, think about it as bringing the team to you through the module so that we could continue to have consultations by the teams that round in the ED. Or if a person is not even in hospital, and again, we've seen the use of technology to keep patients connected. You remember at the beginning, it was families couldn't come at all to the hospital, and we found a way to keep people connected by using our iPad modules, not just with the practitioners that were outside of their rooms, but also with their families outside of the hospital. And also when there was a subspecialty consultant that couldn't come to the ED, for example, especially with our, for example, with psychiatry, dermatology, etc., we can do telehealth consults where people are at a distance. Next. One thing we realized very early on, it's no news to anybody here, is that a patient with COVID can look pretty good now and can get very sick later, and that later might actually be when they're home. The most recent case of that was this weekend, and really taught me how important it is to monitor patients at a distance. So we started a program where if you tested positive but did not have a reason to be admitted to the hospital immediately, we could continue to monitor you at home. And next. The basis of this is a symptom-based sort of questionnaire that is sent to you through your computer at home. When you leave the ED, you're given a pulse ox and a thermometer, and you're given access to try to complete the system-based questionnaire, which is basically a very customer-friendly way of saying, yes, no, I'm better, I'm worse, I have diarrhea, I don't, etc. And the answers to that next, on an individual basis, on an individual basis are loaded onto a individualized sort of sheet, so we can follow a patient over the course of time. And this is in a database that is called QBase. Basically, all of this stuff was developed in-house. And this creates a work queue for the operators that we have in our WEC, our center that answers telephone calls from our maritime calls, all our distance-based patients. All of this goes into a queue in the WEC. And so the operators can see each remotely monitored patient's information on a daily basis. And it creates this dashboard that we can look at our patients as a group or as individuals. And next. Based on that queue, you can go back one, I'm sorry. Based on that queue, if a person is escalating, the WEC operator calls the on-call EMED telehealth practitioner for the day. And then we will call the patient and say, hey, we noticed your temperature is going up, your pulse ox is going down, how are you feeling, and so on, and can bring somebody in. And again, just this last weekend, or I guess maybe 10 days ago, we were following somebody who, interestingly, their pulse ox wasn't working. And that's why we called them, because they called us to say our pulse ox is not working. So we called them to see how they were doing. Kind of doing okay, and started to get a little bit worse. And almost 7 days to the time where they were in the ED, initially, we asked them to come back in, and I happened to be in the ED when the person came back, and they were in that sort of, quote, cytokine storm phase where they had multi-organ involvement, and they ended up going to the ICU. It's possible they might have come back anyhow, but we like to think we caught them very early on because of our remote monitoring capabilities. And I think our data, we're still starting to go through it, is starting to show that. Next. Again, when we saw that tsunami coming and realized the patients weren't going to get to us and we weren't going to get to our patients, we were looking at what was going on in China. We realized we really have to go up on our telehealth capabilities. We looked at our MFA outpatient charting, how we could develop a COVID encounter, how we could get patients registered quickly, and then all of you have been part of this, how we could get our practitioners trained quickly to be able to do telemedicine, at least in this way. A lot of people were already doing distance-based medicine, but a lot of people were not, how we could get people trained up, and a big collaborative effort between all of us, internal medicine, EMED, and everybody else. And we've gotten to the point now that we can actually see that we were able to quickly ramp up, get people trained using peripherals, and kind of making it easy for people who are maybe not as used to using technology to using it, to the point where we're able to ramp up our ability to see patients as outpatients throughout the MFA. Next. In terms of our community involvement, we really realized very early on that there were parts of the city that we've been servicing for health information through our community collaborators. And the health desk is something we had been doing, going out into the community and doing health education, and how we could get that to try to bring COVID education and take away some of this sort of COVID fear and not wanting to engage necessarily with the medical community if people had questions about their health. And so we got out there with our medical students, and it really has, this collaborative effort has really paid off. Again, I want to give a shout out to Gigi, Dr. El Bayumi, and what she's been doing in the community. If any of you have a chance to join in her almost weekly evening conversations with the community, it's been incredibly helpful, and puts this whole epidemic that we're having in this area in context of our greater health disparities and health issues, and is a real resource for people. Next. I think we'll skip this one. We're getting very short on time. And skip this one as well. There's no question about no going back. How can we keep going, and how can we be resilient and innovative? Next. I just want to put this up. There is a new normal. How we address it is going to be up to us. And technology is going to be a big part of what we do. Next. I'll go through my slides very quickly. Next. Sorry, Keith. I'm going to concentrate on two main things. One, testing. From the very beginning, testing has been our Achilles heel. It's been what people want of us. It's been what we've had difficulty providing. And really, the way in which we think about testing, we probably have to reconsider what we consider diagnostic tests and what we'll accept. So we'll talk about testing a little bit. And then these para-COVID issues that just being in the ED, there's certain things that bubble up that even before they hit the literature are very obvious to us. Next.
Tanya, it's Alan.
Yes.
Rather than have you rush through this, I'd rather bring you back another day and have you, go slowly through this, because there's a lot of other topics that I thought of that you didn't have a chance to cover today. The four of you from the ED. Would that be okay, rather than rushing through this now?
That will be okay. Can I go to the last three slides in this?
Of course you can.
Okay. Keith, if you could go to the violence slides, the testing slides. I think testing is a whole huge topic, and so much is happening recently that I think we can. And next slide. Something I want to bring to your attention. One thing we've noticed in the ED is three things seem to be bubbling to the top, and it feels very much like the crack epidemic when it started. There's a incredible rise in gun-related violence that we're seeing in the emergency department, number one. I'm telling you, there's no way to quantify this, but I'm telling you, there is an incredible rise in sex for either drugs or money, and we're definitely seeing this in the ED. And the last thing we're seeing is an incredible rise in drug abuse and coming to the ED primarily because of drug abuse. I'm just going to center on what we're seeing in gun violence. Again, this is palpable. Comparing over the years, so you see this trend going up between June of 19 and now. You can see both violence and homicides due to the guns. That's the red line. Next. And this is, each one of these is a life. And 29 to 40, you might say, 10 more. We're really, it's on an uptick, and the quality of violence has really gone up. We're seeing close range shots to the head, shots to the chest, and not so much of this. I know it's been in the newspaper drive-by, but real extreme interpersonal violence is what we're seeing at a rate we've never, ever seen before. Next. So if you map this out in the 2-month period, comparing last year to this year, clearly our numbers are up. Next. And if you really go down through it, this is the one statistic that just jumps out at me. There's a 38% increase in homicide with a gun. Same time, compared to last year. And we have no reason to think that it's going down. And how this connects to COVID, I don't know, but I really do think it does. And we're looking back at what we, again, what we used to say was Baltimore in the season of crack. And what this will bring, only God knows. But this is another big choppy wave we see coming at us. And I just wanted to throw this out there. And I'm done. Thank you for your patience.
Diane, thanks for doing that, because I think it was important for us to hear, and I hope we can get you back to do more. We are running out of time, but I have one question I have to ask you, and anybody can answer this. Keep it there if you want to answer the group. What was your safety profile? We learned from Danielle that they only had one physician that tested positive. What was your safety profile as far as your staff? And yeah, there he is, our poster boy. What was your safety profile between your staff and your physicians? Could you tell us a little bit? Andrew or David?
Yeah.
Or Tananya again? Tananya again.
Okay. I would humbly say that we cannot say that there's a single attending level physician that converted because of their work in the ED. I think that's fair to say. Of course, not 100% anybody, but I think that's fair to say. In terms of our residents, there's a possibility that maybe one, maybe two was due to exposure. We say the two, but again, there's community. We're in the middle of a pandemic.
Were they early on, the two? Were they early on in the?
No, they were not early on. And that is why I know they converted, but I really find myself doubting. And again, we don't have clade information and this and that, doubting that it happened just in-house. And in terms of staff, again, I don't think we can point to one staff member and say, this was directly related to an exposure at work. We really are pretty careful. And the safety officers have been an important part of this. But again, we're in the middle of a pandemic. We are living our lives. Some of us were living in hotels, living in Airbnbs. Most of us have reintegrated back into our families. And some of us are going to have children that are going back to school. And that is going to make us, that's going to change everything. And so, yes, I'm sorry.
No, I think it's like Danielle said, it's reassuring to hear that the safety measures we've taken work. And the thing I was worried about when I asked if they were early or late is that we could start getting sloppy because we start, not taking it seriously enough. But, this was great. This is exactly what I wanted. I mean, for everybody here, what you have been doing in the ED, all of you, is just amazing. It goes along with the ICU people, with our hospitalists, with all the physicians in pulmonary and cardiology and others that have been working in the hospital. It's just been a terrific effort. So I thank you. I think I would like to have you back to finish up some of this, and maybe we can do a joint thing with the hospitalists and the ICU people. But thank you all for doing this today. There's some other questions, but we don't have time. I'm going to ask people to just contact you directly for that, okay?
Okay.
You all stay safe, especially Jeff. And thank you, everybody. And we're done.
Thank you. Thank you very much.
Thank you.